Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner of the Chicago Department of Public Health. As always, this is your chance to get your public health questions answered. Today is August 23rd, 2022. I had a very nice vacation last week, thanks to those of you who are emailing me. And we're going to be doing some updates with a focus on monkeypox, or what we're really calling MPV, as well as COVID, but also take your questions more broadly. As always, you can put your questions directly into the box below using the hashtag AskDrArwady on either Facebook or Twitter. Let's start with our dashboards. Chicago chi.gov/COVID- is for COVID, and chi.gov/MPV or /monkeypox for monkeypox. But let's look at the COVID one. So everything is looking green except vaccinations administered, and that's good news. We've continued to see this drop in cases. We're averaging 522 diagnosed cases a day here, down from 647. As a reminder, this broadly does not include home-based tests. So there are many more people being diagnosed with COVID than are here, but anyone who's seeing a health provider, anyone who's seeking out PCR testing, those are all automatically reported here, and it does let us track trends. Hospitalizations also looking good, 22 on average per day, down a little from last week, still averaging less than 1 death per day, which is where we've been since coming down that first Omicron surge in January. We're doing about 2,000 vaccinations a day, down just a little bit from last week, but both emergency department visits and hospital beds in use remain within target. So overall, things continue to be quite stable from a COVID perspective. I'm going to pull up some slides here. And we've put these together really to address some of the questions that have been coming in. So first, I wanted to highlight that we've expanded, in partnership with Chicago Public Libraries, our access to free Narcan, or naloxone. That's the spray overdose medication that saves somebody's life if they have overdosed. And we are expanding to have it available free. You don't even need to talk to anybody. You can walk in the front, and they're generally just off to the side, to 51 libraries in August. And this is the list of which libraries this will be available at, and we will plan to expand this program citywide by the end of the year. So the ones in blue here are the 24 branches that are opening. And I really want to thank both teams, the CDPH team and the CPL team. Just since January, we've been able to distribute over 600 kits from 27 branches, and more importantly, trained more than 280 library staff on overdose prevention. Lots more information is available on Narcan access and trainings. That's the email address you can use. You can also check our website. And we're planning possibly next week or the week after to bring a couple of folks on from CDPH, but also from the state, from SUPER, which is the Substance Use Prevention and Recovery branch, just to talk a little more broadly about what's happening with opioid overdoses. So this is just a teaser. Let's talk about monkeypox. So the MPV outbreak does continue to expand. You can see we're at about 43,000 cases now in 95 countries. The countries in West Africa with the blue dots are where we've historically seen monkeypox related to animal to human transmission from small forest animals, whereas the orange is this current outbreak where we've seen more person-to-person transmission, especially by sexual transmission and contact. So it continues to grow, but the good news is we've seen very, very few deaths. These are the countries that have reported any deaths among MPV virus cases out of the more than 42,000 as of last week. You can see that Nigeria, Central African Republic, and Ghana are places that historically have reported MPV, and that other strain is usually more virulent, more serious. The big outbreak, luckily, has been with the version that is that typically makes people less ill. But we have seen, a number of deaths. So we're watching this closely, but no sign of major concern or alarm or worsening of this. And of note, no deaths at this point in the U.S. The U.S. does, though, have the most cases reported. And I wanted to just put this in some context. As of last week, we're about 15,000. Spain was next with about 6,000. If you look by population, it's not significantly different. But in terms of cases, we have reported the most. And this is the distribution as of yesterday of what the total confirmed MPV cases are. We've now seen cases in every state, and Illinois has almost 1,000, and Chicago has 776. Monkeypox case trends reported nationally are perhaps starting to plateau. We're going to talk a little bit about this, but you can see this is each day what is getting reported in. And it's too early to say this for sure. You see that back on August 9th, there were more than 750 cases in a single day nationally. On the 15th, there were 670. But the good thing is we're not seeing the potentially exponential growth that we were seeing early on. So that is reassuring. Want to thank folks who have gotten vaccinated. Want to thank folks who have, been a little more careful with sexual contacts and who have generally been aware. So too early to say things look really good, but definitely some signs of slowing of cases. Illinois, we're the 5th largest state and we're the 6th in terms of MPV cases, so not unexpected there. And Chicago is the 3rd largest city and we have the 3rd highest number of MPV cases, so not unexpected there either. You can see New York has the most, New York City has the most at about 2,500. MPV is very much across Chicago. Residents of 65 of our 77 community areas have been diagnosed with MPV to date. You can see there are still a few community areas where we don't have a confirmed case. We assume, though, that there probably are people with MPV. They may have mild cases. They may not have sought out testing, but broadly, this is very widespread. And every day, Monday through Friday, we're also updating the MPV website. As you can see, you can get there at chicago.gov/monkeypox or chicago.gov/MPV. And as of yesterday, we were at 776 cases. 43 Chicagoans had been hospitalized, especially for pain control or inflammation. We've had no deaths because we've had no deaths in the U.S. And that hospitalization rate has been pretty consistent. We have some potential good news here, too, if we look locally. If you see the number of cases that have been diagnosed by week, you see that the most cases were actually diagnosed the week ending July 30th there at 141. And then the week ending the 6th, just a little bit, 138 down. And then the week ending the 13th was at 113 down. We're still waiting for case reports, often will continue to come in on the latest. But again, not seeing the major increase. And so a big thing that epidemiologists and the whole health department is always looking at with outbreaks is how quickly is an outbreak growing? Is it slowing? And the outbreak may be slowing. I thought I would just show you a little bit of data about how we think about this. First of all, we have to see, is testing remaining high? Because if people have just stopped testing, then numbers would go down without necessarily seeing an actual improvement. So you always have to look at numbers and case numbers and testing numbers together. But also we look at what's called the doubling time. And some of you may remember this. We used this, for example, early on when we were working with Chicago Public Schools and really thinking about what some of those criteria would be. We talked a lot about doubling time because it's a number that epidemiologists use to see how quickly an outbreak is growing. It literally means how long is it taking for us to double the number of cases. So if you go from 2 cases on one day to 4 cases the next day, that would be a 1-day doubling time, et cetera. And you want a longer doubling time. So right now in Chicago, we're averaging, as you can see, through last week, about 13 new MPV cases each day. And the doubling time throughout the whole outbreak has been about 10 days, meaning about every 10 days we've been doubling our number of cases. But if you just look at the last 2 weeks, the doubling time has gone up to a little over 30 days, which tells us that that growth is slowing. So that is a good sign. We want longer doubling time. And so still too early to call, but definitely not seeing signs of an out of control or very rapidly growing outbreak. So that's good. And the other good news is that MPV testing does broadly continue to increase. So you remember I showed you that we peaked in terms of cases potentially end of July, early August, and in the week of August 13th, even though cases were down a little bit, remember, if we look here, cases were down a little bit in that second to last column on the right, testing was actually up. So that is a good sign that at least that week it probably is a real decline as opposed to just a drop off in testing. We're still waiting for test results, to come in this week, and we'll see. I very much want to encourage people to continue getting tested. If you have a rash that you're not sure what it is, go in and get a test because that's critical for us understanding how this outbreak is, getting people vaccinated. The demographics, we've not seen any big changes here. About 44% of our cases continue to be in people 25 to 34, followed by 35 to 44. We've had no cases in children. And we've had about 42% of our cases in white Chicagoans, about 32% in Latino Chicagoans, and about 21% in Black Chicagoans to date. And if we look, we're up to 9 cases that have been diagnosed in people who were assigned female sex at birth, 766 male. And you can see broadly on gender there, which gender and sexual orientation are self-reported. The great majority in men, also some in transgender men, transgender women, 4 in people currently identifying as women, and 95% of Chicagoans who have reported their sexual orientation have reported being gay or bisexual. So that has continued unchanged. We've had 22 people report being straight or heterosexual, and we obviously continue to watch that very closely, but clearly the highest risk is still among gay and bisexual men and others who have sex with men. We're seeing a good match on our geography of monkeypox cases versus monkeypox vaccines. And again, this is by where Chicagoans live. So on the left here, updated through yesterday, you see the darkest areas are where we've seen the most cases. So up on the north, those darkest blue are community areas where at least 51 cases or as many as 147 have been diagnosed. And then as the numbers get lighter, there have been fewer cases diagnosed. On the right, we see where people live who have been vaccinated, regardless of where they're vaccinated. And we do see the most vaccines in the hardest hit communities, so that makes sense. That's what we would expect. I would like to see some more vaccination happening, especially on the south side, though, and we continue to really work on that. We've seen a good match also on age and sex distribution. Nearly all of our cases have been in men. 94% of our vaccines have been in men. The age groups are exactly what we would expect. So that looks good. And we are, as I said, really needing to continue a focus on really encouraging testing and vaccination for both Latinx and Black Chicagoans at increased risk. As one example here, about 31% of our cases have been in Latino Chicagoans, and then as of mid last week, about 17% only had gone to Latino Chicagoans. If you look at Black Chicagoans, when this was last run, about 19% of our cases, I think, as of today, that's up to about 21% of our cases have been in Black Chicagoans, but only about 12% of the vaccines. And so we've been doing some extra outreach. Dr. Luna, who leads on a lot of our Spanish outreach and communications, has been working with many partners and very much wanting to encourage both Black and Latino Chicagoans who may be at risk to get vaccinated. We're seeing an excellent match, though, on the comparison between our cases for race ethnicity and then treatment. Remember, there is treatment available for people who have more severe monkeypox symptoms or who may be immunocompromised. And if you look here on the left, this is the race and ethnicity breakdown of our cases again. And then on the right is the racial breakdown of Chicagoans who have received that treatment. And so we actually see about 21% of Black Chicagoans being cases, and about 19% of our cases receiving TPOXX are Black Chicagoans, and 31 to 33, et cetera. So I'm pleased with that. It lets us know that people are able to access treatment and that a lot of the work has been good there, but the vaccine continues to lag, and I am a little concerned about that. I wanted to just quickly give you an update on what's happening with intradermal injection. We talked about this when I was on a couple weeks ago, but the FDA issued an emergency use authorization that lets the MPV vaccine, the Jynneos vaccine, be administered in smaller doses by a shallower, what's called an intradermal injection. You can see up on that top picture there, it's like a tuberculosis skin test. You just do a smaller dose directly under the surface of the skin, and that gives the level of protection like a deeper one with a larger dose would be. And so it's letting vaccinators give up to 5 vaccinations. In practice, we're actually seeing it more often before, because you still need to pull up the appropriate amount of vaccine. But in any case, 4 to 5 vaccinations rather than just 1 from each existing vaccine vial. And that really increases our reach of vaccine. It's been a game changer, I would say, here in Chicago in terms of the number of appointments we're able to have available, how far we can stretch vaccine, and I'm pleased about it. So good news is that as of last week, the large majority of vaccination sites in Chicago had switched to this mode of administration. There are still some that are needing the new needle millennials that are working on the training, but the great majority have switched over. I want to, a question we were getting a lot was, if I got my first dose subcutaneous, can I get my second intradermal, meaning this more shallow infection? Yes, you can. And that's been really, really good news, because it means that we don't have the extreme limitations that we were seeing early on for vaccine. And so with that, last week we announced an expansion of our MPV vaccine eligibility. So the bottom line is that now all sexually active men who have sex with men are eligible for vaccination. You remember before, when vaccine was very limited, we were having to limit it to men who have sex with men who also had other risk factors, multiple or anonymous partners, et cetera. And so you can see specifically, to be eligible for an MPV vaccine, you just need to live anywhere in Chicago or Illinois. We often get the question, if I don't live in Chicago, can I get vaccinated in Chicago? The answer is yes. And you shouldn't get vaccinated if you've previously had MPV, but otherwise, the main group that we continue to focus on vaccinating are close contacts. So any household members, any intimate partners with anybody diagnosed with MPV. And so I want to just highlight, those are not people who have monkeypox. Those are people who have been exposed. And so that's the setting in which you might see more women, or you might see some children, if they're household contacts, potentially being vaccinated. That remains our top priority. But then secondly, we just say also gay, bisexual, or other men who have sex with men, or transgender persons who are sexually active. So if you're transgender or gay, bisexual, or other men who have sex with men, you are now eligible for getting vaccinated. So especially, we want to encourage folks in that group to get vaccinated if you met recent partners through online applications or social media platforms. When we've been doing our case interviews, we're hearing that meeting people online is one of the biggest risk factors that people are reporting who turn out to be diagnosed with MPV. So that's Grindr, Tinder, Scruff, etc. Also clubs, raves, sex parties, saunas, etc. So as a reminder, MPV vaccine not recommended for the general public. As the vaccine supply increases, we may evolve that guidance. But right now, this is big news. Anybody who is gay, bisexual, or another man who has sex with men can now be vaccinated. And the other news is that people can go ahead and get that second dose of the vaccine. Remember, there should be at least 28 days between your first dose and your second dose. But for a few weeks there, we were really holding off on giving people second doses to make sure that we could get more high-risk people with the first dose. And so now you also can sign up for and get your second dose if it's been 28 days since your first dose. CDPH has really ramped up along with our partners. So we now have MPV vaccinations available 6 days a week at 3 CDPH specialty clinics. These are clinics that always specialize in sexually transmitted infections. This is still by appointment, but we have a clinic in Lakeview, a clinic in Austin, and a clinic in Roseland. And you can register at getvaxchi.chicago.gov or go to the website and find a link. So please sign up. We've added a lot of overtime. We're doing Saturdays, and we love seeing folks come in, get your vaccine. You can also get tested if you want for any other sexually transmitted infections and get good care. And then also this Saturday, we've been doing some of these larger vaccination clinics on weekends. And so this Saturday, we will be at both Wilbur Wright College and Richard J. Daley College with the ability to do hundreds of vaccines, 9 to 2, and that's where you can sign up. Those codes are also available on our website. So we'd love to see people come out and get vaccinated. We have many, many vaccine clinical providers. You see on the left here, these are our larger scale MPV vaccine clinical providers. On the right, this is kept up to date on the website. These are the providers who are offering vaccine, not just to their individual patients, but in a larger way. So you can reach out to any of them as well. I want to thank all those partners. They continue to really do amazing work. There are dozens of more providers that have a small amount of vaccine if they diagnose someone. And we've seen MPV diagnosed at dozens and dozens and dozens of providers, and mostly primary care providers across the city, so that's good. Also continue to do a lot of mobile and LGBTQ focused vaccination events and locations. Want to thank all of those partners and more. And I did want to give an update on the correctional facility case. You may recall that back in mid-July, we had the first known MPV case diagnosed in a correctional facility. It's really important when you have an emerging disease that's behaving differently, right? We've known about MPV for 50 years, but the way that it's being spread person to person is different. And so certainly lots of concern, especially early, and important to put a lot of extra epidemiologic research and work into understanding spread. So the case that was diagnosed in the correctional facility here had spent 7 nights in shared dormitories with a total of 55 other people. All of those people who were in the jail were offered vaccine. About a quarter of them chose to receive the vaccine. It's up to people. But all of those folks were followed daily for any possible MPV symptoms. And I'm pleased to say that all of those folks have now completed the full 3-week that we would follow up days of monitoring, and we've not seen any additional cases. So that doesn't mean to say it's impossible for it to happen, but this is what we were expecting based on what we know about MPV, that even in these congregate settings, we're more reassured. Obviously, during COVID, we saw very large outbreaks in correctional facilities. It's very clear that MPV is much less transmissible than influenza, than COVID. We're not seeing spread through casual contact. It really is more close, direct contact with lesions, and especially through intimate contact. So just as a reminder, we're asking people to turn on the lights before you turn off the lights. If you're sexually active, spend a little time with your partners. Really talk about MPV, look for any new or unexplained rashes or sores. And if you see something, please see a health provider. And there's much more available on the website. If you have any questions about monkeypox, you can visit us. You can also call 312-746-4835. We operate that 7 days, or our STI resource hub at that number. And we can help figure out whatever your needs are. And we've not seen problems with wait times at all for this call line. So you should be able to get through if you've got questions about MPV. Quickly on COVID, the major update is that yesterday, Pfizer and BioNTech announced that they've asked the FDA to authorize that updated version of the COVID-19 vaccine. So let's talk about this for a second. This is the one that's designed specifically to target the Omicron subvariants that are right now dominant in the US. So more than 90% of our cases right now across the whole US, they're caused by Omicron BA4 and BA5. But the original vaccines were designed for the original coronavirus strain back from 2019, 2020. And so as the virus has continued to mutate, the vaccine has been a less good match. And that's why we've seen more breakthrough infections. So the company submitted preclinical data to the FDA. This is called a bivalent vaccine. And I wanted to just explain what that was. It's a mix of 2 versions of the vaccine. It both would be expected to boost protection against the original coronavirus strain in the way that boosters have all along, but also would have new protection against the BA4, BA5 Omicron subvariants. So this now, the FDA needs to review the data, the CDC needs to look at it, but if everything gets authorized and approved, distribution could start soon, and I do think that vaccination may begin as soon as next month, September, so that's really good news. We continue to see COVID hit all across the world. We're up to almost 600 million cases and more than 6 million deaths. But we've administered 12.3 billion vaccine doses across the world. Across the U.S., you can see Chicago right now is doing better in terms of cases per 100,000 population, at 19 cases per 100,000 people being diagnosed formally per day, compared to 28 across all of Illinois and 28 nationally. You can see there are some hot spots, especially like eastern Kentucky and some other scattered places. In last week's CDC update, 75% of U.S. counties were still reporting a high or medium COVID level. That was down just a little. We were at 80% the prior week. This is updated on Thursday evenings. You can see Chicago and Cook are in yellow there. We remain at that medium level. And the reason we were at that medium level is that Cook County dropped below an average of 200 cases per day. Although across all of Cook County in the region, we continue to see hospitalizations. It also includes other nearby counties, are still relatively high, but they're low in Chicago. We're averaging just 2.4 admissions per 100,000. So overall, I think things continue to be reasonably stable, but COVID is definitely not over. Very good news is that everything we're seeing is still all Omicron, and it's now nearly all BA4 and 5. So each of these columns shows a recent week, and you can see that that's late May over on the left up through August 20 on the right. And you've seen the way that the green really replaces the red and the pink. And that is BA5, which is the most contagious version yet, taking over. And so the good news is that we've not seen a new variant emerge yet. And the new vaccine, remember, was specifically made, and it was delayed a little bit, to be able to cover BA4 and 5. So my concern was we might see, before we were able to get the vaccine out, we might see another new variant emerge and you'd be right back where you started. So I'm really pleased that we are still seeing virtually all BA4 and 5 at this point. And the whole country is seeing BA4 and 5. So hopefully if this pattern can hold and we can quickly roll out this updated vaccine in September and we see a lot of good uptake, it would, I think, have the potential to really help cut the risk of breakthrough infections, have a significant impact on transmission. So much more to come as we learn about this, but this is good news. The timing of an updated vaccine compared with the recent mutation is very promising. In Chicago, we are still not where I would like us to be, especially for young kids on vaccine. You look at 0 to 4-year-olds, still just under 11%. And I'll tell you, Chicago Public Schools has, only just gone back to school, of course, yesterday, and I want to welcome kids back to school, and I'm really confident with the procedures that are in place. I feel very good about it. But we have some other schools that have been in session already for a few weeks, charter schools, private schools, et cetera, and we have already seen some COVID outbreaks, and that is especially true in the little ones, kindergartners, et cetera. And so we're going to be monitoring. We have a good thing in place, but please, 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 get vaccinated, get your kids vaccinated. It's the most important thing, truly, that you can do. I also just wanted to review, this is my last set of slides here, and then we'll turn to your questions. I want to really review again isolation versus quarantine. A lot of people use the word quarantine indiscriminately, like to mean I need to stay home because I'm sick. Technically, isolation is what we call people who have to stay home because they are sick, because they have tested positive. And quarantine are for people who have been exposed but don't have any symptoms. I know that people use these interchangeably. I don't really mind, but I want you to understand the difference because there is a difference in terms of what it means for what you need to do if you get COVID. So on isolation again, anybody who tests positive, nothing has changed. The updated CDC guidance did not change that. Anyone with a positive test must stay home for a minimum of 5 days from the onset of symptoms or a positive test. And then if those symptoms have improved, you can return to work or school at day 6, but you generally need to mask through day 10. Okay, so nothing has changed there. You got to stay home if you test positive for COVID, regardless of vaccination status. The change was to quarantine. That's for people who were exposed but don't have symptoms. And so previously, if folks were unvaccinated and there was, for example, a COVID case in their classroom and they were close contact, they had to stay home. But when we looked at data, we were not seeing a lot of conversions, a lot of people switching, and we've seen the real detrimental effects of kids missing school. And so the CDC changed. The state went along with it. Chicago went along with it. We fully agree with it, that we are no longer requiring people to stay out of school and work just because they've been exposed to COVID, that regardless of their vaccination status. But there are 3 things that we need folks to do if they've been exposed. You should monitor for symptoms for at least 10 days, test if you develop symptoms at any point. You should mask for 10 days after exposure, regardless of symptoms, and you should make sure. Take a test, regardless of your symptoms, at least 5 full days after your last exposure. And we've made some more graphics just to highlight this. If you test positive, no change here. Days 1 to 5, you got to stay home and away for others. And you should talk to your doctor if you're at high risk for severe illness, because these are folks who we might want to give Paxlovid to or other treatments. Day 6 or later, you can end isolation if you never had symptoms or you're fever-free for 24 hours and other symptoms have improved. And then days 6 through 10, you got to wear a mask, or the CDC did include if you have 2 negative antigen tests 48 hours apart, you could stop wearing the mask. But in practice, that means you're going to be wearing a mask at least through day 8 or 9. And frankly, it's probably the most straightforward just to wear the mask through day 10. And for that whole time, you want to avoid people who are at high risk of getting very sick. Regardless of the COVID community level, you need to mask if you have symptoms of COVID, if you have a positive test, or if you're exposed to someone with COVID. So that's straightforward. This weekend, Saturday at Wilbur Wright and Richard J. Daley, we've got 9 to 2 adult and pediatric COVID vaccines and boosters available, all Chicagoans. You can register. We've got both Pfizer and Moderna for the little ones, age 6 months through 4 years, and we've got Pfizer for everybody older. And our Get Vaccination at Protect Chicago at Home program continues. So this has not stopped. This is one of the most unusual things we do in Chicago. Anyone over the age of 6 months can get a COVID-19 vaccine at home for free if they live in Chicago, no questions asked. We'll do Moderna or Pfizer. Moderna for the little ones. We'll do boosters. We'll vaccinate up to 10 people, and we will make an appointment so you don't have to wait around for us. Saturdays, Sundays, Mondays, or Tuesdays, 8 a.m. to 6:30 p.m. And through the end of August, any Chicagoan over 5 can also get a $50 gift card for booster doses. Reach out, chicago.gov/at-home. You can schedule without talking to anybody, or you can call, and we're happy to make you an appointment. So as you see, our hotline is the same in terms of the being able to answer your questions about MPV or COVID vax. And appreciate all of your attention. Let's turn to some questions. Okay. So a number of questions about masks and Chicago Public Schools. So Meg from Twitter says, when will you update your mask policy for schools, specifically CPS? COVID is here forever. Are masks here to stay forever as well? So I'm not sure if you have a child in CPS, but there is not a mask requirement in place for CPS. So I'm not sure where you heard that. Masks continue to be strongly recommended in schools. We continue to be at a medium level. We get down to a low level, like we'll talk. But also there are times that masks remain required. If your child is diagnosed with COVID, they have to stay home for 5 days, and they need to mask for days 6 through 10, unless they're doing some of that negative testing in the second part. And if your child has been exposed in the classroom, they need to wear a mask. It's like an umbrella. You don't have it all the time, but you pull it out when when it's raining, when there's the potential for exposure. So if you have a more specific question, I'm happy to address it, but that is the policy. That is consistent with guidance across the country. All right, let's take, a number of questions about the Narcan. Okay, good. So like I said, we're going to do a focused conversation about opioid overdoses, but I see, Alina on Twitter says, sounds like she doesn't like this. She says it's a great plan to make the library a life and death situation for children trying to further their education. Next, you'll provide Narcan directly at schools. How about working to get drugs off the street, work on ending the problem instead of extending it? Ann Elliott from Twitter says, wait, we want libraries to be sanctioned injection sites now? And Old Army Nurse on Twitter says, why don't you promote getting clean and sober? Is that too moral for you? So let me explain a little more about Narcan, and then we'll take some more time when the folks are here, probably next week. So Narcan is an absolute life-saving medication. Anybody who is being prescribed chronic opioid medications should also be receiving a Narcan prescription. We regularly are now seeing fentanyl, which is the really strong version of an opioid. We are seeing that contaminating a lot of other drug supplies. So 10 years ago, this was really mostly about heroin. We now see opioids in a lot of other medications, including, not prescribed medications, but illicit, where people are buying pain pills off the internet, or kids are experimenting with what they think are, relatively innocuous party drugs, etc. Of course, the number one recommendation is not to use this, and especially with younger people. We have a lot of information really discouraging drug use, but it is also really critical that we use something called harm reduction. And I would like nothing more than to have many, many people carry Narcan. I carry Narcan in this city because if somebody has overdosed and stopped breathing, Narcan is what saves their life. Probably more lives get saved every year in Chicago by people carrying Narcan than by people knowing CPR, to be honest. And so we want to make sure that anybody has access to Narcan. I don't use any illicit drugs. I carry Narcan because I want to be ready. There have been multiple situations in my life that I have been close to an opioid overdose, and that is not just in my practice as a doctor. And in the same way that Chicago Police Department, we want to thank them. They all carry Narcan. Of course, the Chicago Fire Department and our EMS colleagues, they come and they take over the official. But we've really worked to make this medication widely available because it saves lives. It is different than getting people into treatment. And I want to emphasize that if somebody has had an overdose, especially if they use drugs chronically, the other piece that goes along with that is encouraging folks to get into treatment. And you'll see if you go pick up the information about Narcan that is paired with information about how to get into treatment. We've got a 24/7 hotline that will get people the medication that can help get them treated and their opioid use disorder treated. But it is not the right approach to pretend that this isn't happening. Opioid overdoses are a major cause of death in Chicago. More people die of an opioid overdose every year in this city than die of gun violence and car crashes combined. And Narcan is what saves lives. So I'm really proud of this work to distribute it, and you should be thanking people who carry Narcan, not in any way going against them, because I consider it a life-saving venture, and we really encourage any Chicagoan who wants to help save a life and maybe around folks at risk of an opioid overdose to have it available. You always call 911 too, of course, but if it takes 10 or 15 minutes occasionally for that to happen, for the response to get there, by that time the person typically will have died if they have not received Narcan. And CPR doesn't do it, the medication does. So thanks, and please tune in when we have some more discussion about this. So Liz on Twitter, how many kids under 5 have received a COVID vaccine in Chicago? I posted that. I shared it. It's about 11%, but the numbers are there. If you go to chi.gov/COVIDvax, you can look day by day. You can see what the numbers look like, and let me know if you have additional questions. Didi Ruiz on Facebook, will the booster shot be available for people below 50 years old soon? No. So I think what you're asking about is that, as you'll recall, we recommended booster shots, and this has probably been for the last 9 months or so. We've recommended a booster shot for anybody over 50 or anybody with moderate to severe immunocompromise. The reason we're not recommending a booster shot for people under 50 is that this updated vaccine is coming. And the updated vaccine is better protection against especially Omicron BA4 and BA5. And so if you are under 50, you will be recommended to get that updated vaccine, potentially as soon as next month. But you otherwise should not get another vaccine before that. We want everybody up to date. So if you're over 50 and you haven't had your dose, go ahead. But for people under 50, like me, I have not had another booster, okay? I'm waiting, and I will get an updated vaccine when it is recommended for me. All right, so a couple of comments about MPV. David Damian on Twitter says, has Chicago received any federal funding for monkeypox? So at this point, we have not received any federal funding for monkeypox. With the emergency declaration, we've started to see some more flexibility in our ability to use funds that were granted to CDPH for other purposes. So for example, where we have received funding to support COVID vaccination or COVID COVID testing. We still have to fill out paperwork and be very specific about how we want to redirect some of those funds. I have all these nurses working overtime. I need to specifically ask, is it acceptable for me to use funds that came in for this other public health outbreak for this outbreak? I'm hoping that that gets a little easier, but we've at least started to see some flexibility there. But no, we've not received any federal funding. More than funding, though, what I need is flexibility. So that, you've heard me say this a lot, we have a habit in this country of only funding after an outbreak starts and specific to that disease. That is not the way to set up strong public health systems. Instead, we need lower, consistent numbers of funding that let me fund nurses all the time, that let me fund outreach all the time, that let me make sure we can be working on opioids and chronic diseases and all the things all the time, but then be able to quickly shift those resources if something unexpected emerges. Also, a couple of comments here that I just want to address on MPV. So Diane Lynn from Facebook says monkeypox spreads through the male gay community. That is true. I'm not sure what your question is there. I think, you know, the majority of cases that we have seen have been in men who have sex with men, but as you heard me say, there have been cases in some women too. Not very many, but people who are close contacts, right? If you're a household contact, if we see people, you know, hugging, having close contact like you would in a household, we've also seen a little bit of transmission in those settings, and we've seen people who are bisexual having that transmission. So I'm not sure if you have a question there, but the majority of cases continue to be in men who have sex with men, but not exclusively. And there is nothing about this that makes it, you've heard me say this too, it is not a disease, there's nothing biological that makes it be more likely for people who are gay to be diagnosed. It's just that that is the social network and the sexual network, frankly, that it has been first spreading in. Okay, and I see at Flapjack4924 from Twitter, he says, or they could just use condoms to avoid getting infected. Thank you for that question. Condoms can help, but they absolutely are not 100% protective, for sure, against MPV. And that is why we encourage people to have the conversation and to take a look. Because here's the thing. Yes, a condom, you know, if people are having any riskier sexual activity, a condom is important. It protects against HIV. It protects against the sexually transmitted infections that can be in semen, for example. But remember how MPV is spread? Through close contact with lesions anywhere, potentially through extended kissing, respiratory secretions, etc. And so a condom does not protect against MPV. It probably helps, but this is why we need anybody with a lesion to be getting tested. It's also why we don't call it just a sexually transmitted disease, given that it can be transmitted in other ways. So thanks for that comment, because that's a good thing for me to clarify. I appreciate that. All right, so some more COVID questions. Chris Wilder from Facebook says, NBC Chicago's Instagram keeps posting about BA 4.6 and posing various questions about maybe outcompeting BA 5, being more dangerous, etc. What's our take on BA 4.6? So obviously CDPH has been monitoring BA 4.6, just like we monitor any potentially emerging variant, subvariant strain. And I've not seen anything at this point that gives significant concern. We were especially concerned at the beginning about BA 4.6 when it emerged in India, because it looked like it was outcompeting a little bit. We've not really seen that bear out, though. So yes, we've seen some cases of it in Chicago and Illinois, but the graph that I showed you shows, you know, BA 5 is by far the most contagious, and that has continued to grow, and that's been true since BA 4.6 was developed. So I always tell people the time to be concerned about a variant is when it gets a specific name. Remember, we call them variants of interest. If we're interested in them, we're watching them. We call them variants of concern if there is something about them that is really concerning from a public health standpoint. And then there's a third level, which thankfully we haven't had yet, which is a variant of high consequence. If a variant of high consequence came along, that would mean like the vaccine doesn't work against it. It's really putting people in the hospital. The test doesn't work. Something's really different. And if we got a variant of high concern, that's the sort of thing that would really put us back a huge step. But BA 4.6 is not a variant of concern. These are all part of Omicron, and it's like a subpart of BA 4. So I think it's good to be monitoring, and of course we are. But the good news is that the updated vaccine should help a whole lot against BA 4, BA 5, and all of Omicron. Francie Swidler from Facebook is asking, is headache a symptom of COVID or rash? Are there any new symptoms reported as it evolves? So Francie, I would say, we continue when we do our case investigations, when we're reaching out, we continue to track this. When I think about the things that are looking a little different in the more recent cases of COVID, which again are these newer variants, there's a few things that I notice. First of all, the biggest one is that people are so much less likely to get seriously ill, right? That is predominantly because people are vaccinated. That is the number one reason. But we also know that about more than 95% of Americans have now had at least one immune lesson against COVID. They've either been vaccinated, like I have, or they've had COVID, or both. And that means that the immune system is better at being able to protect against that severe illness. But what we have been seeing more recently, first, there was an interesting study recently that out of Asia that pulled together a lot of different studies about COVID and was able to show pretty conclusively, and we knew this anecdotally, that we've seen what's called the incubation period shorten. So if you go back to like alpha variant, beta, delta early on, it was about a 5-day incubation period on average. So if you were exposed to COVID, on average, we were seeing people, it'd take about 5 days for someone to end up testing positive. And remember, that went from 5 out to 10, out to 14. The reason we've been able to back up why we only use 10 days now is because that timing has shortened. So more recently with BA4, BA5, that's all the way down to about 3 days now. So on average, people are testing positive about 3 days after, but you can test positive up to 10 days. So that's been one thing, that it's moving, the whole thing is moving a little faster. That is excellent news from a control perspective, because one of the biggest challenges of COVID is that you can have, when the incubation period is long, you can get infected with COVID, potentially have a long time before you have significant symptoms and still be spreading it. So it's good news to see that incubation period getting shorter. So that's been good. In terms of symptoms, we're seeing more what we call upper respiratory symptoms with more recently. We're seeing a lot of more sore throats, fatigue, still seeing some fever for sure, runny nose, less of the sort of affecting the lungs, kind of whole body. And some of that is just, again, as it's fast moving, it's able to sort of get in through nasal passages and cause those early symptoms. But then the other parts of your immune system kick in and help protect sort of the lower respiratory. So headache can definitely be a symptom of COVID. It's not one of the top ones. Rash can be a symptom of COVID, but it's not one of the top ones. We've not seen new symptoms reported. We're seeing less of the losing taste and smell than we were early on, but we still see some of it. And I'd say that's the most what we call pathognomonic. If somebody has lost taste or smell, that's COVID. Like there's really not a whole lot else, at least on a population level, that does that. But otherwise, it continues to present like a cold, like a flu. There is no way to know if it is COVID or something else without getting a test. And that's why we encourage people to make sure you've got your free at-home test and just test a lot. I got back from vacation yesterday. I took a test just to make sure I was negative. There's no symptom that you can say for sure this is COVID or isn't, but we've not seen it get more serious, and that's good news at this point. And Alexandria Dion on Facebook says, which COVID symptoms last the longest? I feel like some of mine went away quicker than others. Yeah, definitely. Always the symptoms that are going to last the longest would be a cough, or almost always. I shouldn't say always. Cough tends to be the most lingering effect. That's true whenever you have any viral infection. You can be feeling totally better. You're still going to have some irritation and potentially cough. Doesn't mean you're contagious past 10 days, but that's usually the last to go away. Fever, we pay a lot of attention to fever because fever, while fever is ongoing, there is a lot of inflammation in your body. You're often very infectious. And so that we usually see go away sooner. And then you'll see, the fatigue can often continue for longer. The cough can continue for longer. But the fever will often go away first. And again, that's where there's more information about, like, regardless of your symptoms, even 0 symptoms, you have a positive COVID test, you need to stay home for 5 days at a minimum. And then if you're feeling better, come out. Kristen Korkowski on Facebook is saying, is it safe to travel out of state? Are there any new COVID risks to be aware of? I'll be traveling to Massachusetts and Rhode Island in 6 days. My boyfriend and I are boosted. So excellent question, Kristen. I do think it is safe to travel out of state. I just traveled last weekend. There are not new COVID risks to be aware of, except that a lot of people are taking fewer precautions with COVID broadly. So I would say travel is still generally a somewhat higher risk activity. The most important thing you already said is that you're boosted. So if you're totally up to date with vaccine, you've done the most important thing. I would also encourage you to wear a high quality mask. Get a KN95, wear it on the airplane, you know, especially in the airport when you're interacting with a lot of folks. And just be a little bit extra careful, because by definition, when you're traveling, you're usually in a lot of environments that are pretty different from what you might have here. I always travel with a few COVID tests in case I get a symptom. But yes, I think it is good to travel. I think we are, we're doing okay as a country, to the point of somebody earlier, COVID's not going to be gone. And right now, I'm very comfortable with people traveling. If the place you're going is high risk, you can look at that also on the CDC site. Take a look at those counties. If they're low risk counties, you're actually in really good shape. If they're medium risk, it's going to be similar risk to here. If they're high risk, know that is probably a little bit higher risk. But I don't, I encourage people, in fact, to do the things that we love, because I don't know for sure what the fall and winter are going to hold. I'm hopeful with this new vaccine that we'll maybe get more on top of this for breakthrough infections with BA.4/5. But this virus does continue to mutate, and I'm more confident saying now is a good time to travel in the summer. You can do things outside, than being able to predict in December, January, February, especially remembering what our last December, January, Februarys have looked like for the last few years. And then finally, Kimberly Guerra from Facebook says, I spray and wipe down common surfaces with rubbing alcohol. Is that a strong enough cleaner? So I would say you really want to use a cleaner that is designed for cleaning surfaces. Back in the early days of COVID, we spent a lot of time kind of talking about this. Anything that contains alcohol is broadly going to be perfectly good for killing viruses broadly. But I always encourage people to use solutions that are designed for cleaning. And there's special things about labels that you can look up. I might actually, just if you're interested in this, perhaps next time that we're on, I have not talked about sort of cleaning surfaces in a really long time. It's not the top priority, right? For COVID, for MPV, for anything else. But I do want people to continue to spray and, your regular cleaning, especially, schools continue to do really good cleaning. Common things lots of people are touching, like doorknobs. You want to clean them, not just for COVID, for other things. But you don't need any special fancy kind of cleaner. You just need to be using a cleaner that is good against viruses broadly. And that's true for both COVID and MPV, and really any other vaccine. Any other virus. Okay. We are at 12 o'clock. Let me just see what I didn't get to. Susan Villanosa on Facebook says, would everyone be eligible for the updated vaccine? I don't know yet. So this is exactly what the FDA, the CDC will be looking at. I expect that all adults will be. I don't know about kids. But I also don't know whether we'll start with highest risk. I don't know yet. So that's one of the things that we're watching the most. And I expect over these next few weeks, we will have significant answers for. But my expectation is probably all adults will be eligible. And it sounds like there's been good production already. So I don't anticipate major problems like at the very beginning of COVID when it was really hard to get a vaccine, but we just don't know yet. And we're doing a lot of planning at CDPH because September is always a busy month for us. We got to get all the kids up to date with their required school vaccinations, and to be in school in Illinois, you only have till October 15 to make sure kids are up to date with everything. And so we're often doing a lot in conjunction with not just CPS, but other schools around getting kids up to date with vaccines. We, of course, we always see an increased interest, and CPS continues to offer really good vaccine clinics, lots of them for kids, for families. But so back to school is always sort of September. We have our ongoing MPV outbreak that is needing a lot of vaccine resources. We're now anticipating a major new COVID vaccine update, which will be a big, I'm excited about it, but that's a pretty big operational lift for the department. And then finally, that often marks the earliest part of when we start doing flu vaccines. So you're going to be hearing a lot about vaccines sort of over the September, October time period. We've already been scheduling, for example, we offer flu clinics through all the aldermen's offices. We've been working to figure out, we'll probably offer COVID vaccine through those too. We just don't know yet. So much more to come on that, but we will let you know when things are available. And there's a couple questions here wondering about testing. Liz on Twitter is asking about, are there in light of CDC updates that guidance is similar for vaccinated and unvaccinated people, are there remaining places in CPS that have discriminatory policies? So once again, I am very, very confident in what CPS, but not just CPS, right? We don't just work with CPS. We have the responsibility for schools across the city have in place. They are meeting or exceeding all CDC guidance. And, for where we are in COVID, I think it's appropriate. We'll see. If this next vaccine turns out to be very protective, we'll be strongly encouraging adults, especially, to probably get an updated vaccine. But all of that is to come. All right. So if we didn't get to, I see there's a question here about Paxlovid. We'll do that. I see a comment here from Jake Kane wondering about the CDC guidance and wanting the American Academy of Pediatrics to respond. So I'm a member of the American Academy of Pediatrics too. So we are at time, but I'll hit on some of these questions about testing and Paxlovid and CDC guidance again as needed next time that we're on. Tentatively, next week, August 30, we tentatively will have an opioid focus with Dr. Gastela and Dr. Jasmine. That could get moved to the following week. It depends a little bit what else is happening. But in the meantime, we're doing well from a COVID and an MPV perspective right now. Please get your vaccines. If you're newly eligible for an MPV vaccine, please come up to date if you're not for a COVID vaccine. And we will see you next Tuesday at our regular time, 11 a.m. Thanks.